Okay, so I mentioned we've got 3 coalitions. We have one from Tuolumne, one from Lake, and one from Northern Sierra, which includes 5 different counties. Yeah, Plumas, Modoc, Lassen, Sierra, and Siskiyou. And it seems that MAT is one of the really challenging areas in this challenging work that you are all doing to fight the opioid epidemic. But what we've brought to you are 3 speakers who I think will give us a lot of hope in this area for the kinds of strategies that they're implementing. I will introduce Dr. Liza Ortiz first. She's the health officer for Tuolumne County. And we also have Dr. Mark Satterfield. He is the health officer of Plumas County. And thirdly, we'll have Kimberly Tangerman, and she's the clinic director for a multi-specialty FQHC clinic in Lake County. So let's welcome Dr. Liza Ortiz.
Hello, can everybody hear me? Yes? Who has heard of Tuolumne County before? Please raise your hands. Oh my God, everybody. It's a miracle. I moved to Tuolumne County from Chicago. I had never heard of it before. I'd been to Yosemite, but through the Mariposa County part of it. So I moved to Tuolumne County a little over a year and a half ago, and I always joke around that the health officer told me there was an opioid problem, and I go, yeah, sure, so does everybody in a rural community. And then I get to Tuolumne County, and I'm like, Todd, you didn't tell me it was this bad. So we had a funny confluence of events. A prescriber got arrested and had to give up her license due to inappropriate prescribing. And it really coalesced a lot of different partners to be interested in the opioid epidemic. It also happened to coincide with the release of numbers from Brandeis and the grant opportunity from the Healthcare Foundation. And if you saw the numbers, which I think were from 2013 data, from Brandeis back when we applied last year, Tuolumne County is number 3 out of 58 in terms of numbers of pills prescribed to residents in this tiny little cute rural town. And so there are some prescribers who have been prescribing MAT for a very long time. Most of them, not very much of it. And then a couple who were basically running MAT clinics integrated into their primary care clinics already, but not necessarily seeing Medi-Cal patients and still kind of limited because you're just the one person. So we started having, at first, weekly meetings in the summer and fall, and we've moved to monthly meetings. And when we started off, there was no interest in really even taking pain patients whatsoever from a very large number of our primary care providers. And then, even less interest in MAT and getting a waiver, and rewrote into our grant that we would use some of the funds to reimburse physicians getting their CME and waiver, which we have done for 2 physicians in the past couple of months, and I'm this close to one other one. But we had 2 prescribers who were doing MAT quite a bit in their primary care clinics who really wanted there to be a more organized MAT option in Tuolumne County. And through sitting at the table with the guys from the hospital over and over and over, finally kind of convinced them that this was a reasonable thing to do and that we needed this in our community. So we have one hospital in Tuolumne County. It's called Sonora Regional. It's run by Adventist Health. They own the Rural Health Center. And at the Rural Health Center, they only see Medi-Cal patients. We have the wonderful blessing of having 2 large tribal clinics that are willing to see some of our other Medi-Cal patients as well. But as in any rural community, we have a huge crisis of primary care in general. So the Rural Health Center was already filled to capacity. And initially when we started this, they weren't interested in taking on even more people. But little by little, they kind of came on board. I think they just kept hearing the same message that, yeah, MAT can be a really great experience. And a lot of primary care providers, myself included, have had a lot of negative experiences with chronic pain patients and patients who are diverting. and that's a very different experience than what the MAT experience is. So they have been running a clinic there since the summer, 2 half days a week with 2 different physicians who are waivered. And basically anybody in our community who has Medi-Cal can be referred there, and they're accepting patients all the time. So there are, of course, insurance barriers, as there always are, but we're trying to work through them. And we had one of the other newer prescribers who just got waivered, has been accepting those patients who cannot be seen at the rural health center, get to go to this other guy who does accept private insurance. So that's very broad strokes of what it's like in Tuolumne County. I don't know if any of you guys have specific questions. I know there are different models. You can really integrate it into your routine primary care, which some of our other Medi-Cal clinics would like to do. But for us, having the separate MAT clinic gave some comfort to physicians who weren't willing to get the waiver. At least there's an option for some of those patients. So.
Great. Let me bring a microphone to you. And if you could introduce yourself and where you're from before you ask your question.
Yeah, hi, I'm Jean Marsters from Lifelong Medical in the East Bay. Wondering what your patient scheduling is like. How long do you do intakes for your MAT clinic? Who does what work? If you and the other speakers in this section could comment on that, we'd be interested in knowing what your patient flow looks like. How long till intake? How long until induction? All that stuff. How many weekly visits until the patients stabilize enough to be able to do every 2 weeks or every 3-week visits with the provider, that kind of stuff.
Sure. I probably can't answer most of those questions for you, but I'll give you a card and I can put you in touch with people who can give you all those answers. I could give you the broad strokes of they have to have a referral from a PCP currently at the rural health center and a PCP who is a Medi-Cal provider. So for the people who are waiting to even get into the system, we have like a 2-month wait list to even be seen as a new patient. But if you are either a patient of the tribal clinics or of the rural health center already, you can be seen within 2 weeks, if not faster, because we just have the capacity right now because it's still pretty new. And longer first visit. I don't think they do the full hour for the first visit, and then the follow-ups are 15. So, and most of the work, it happens to be at this clinic currently, most of the work is done by the physicians. We don't have a nurse or a case manager, but we're small enough that they can get away with that for now.
Great. Other questions? Can you talk a little bit about how you convinced the almost 3 docs now to get their license? That we hear a lot about kind of resistance and fears.
They just needed to hear over and over again from a experienced provider that it would be a positive experience. It didn't happen in a month or one 15-minute conversation. It definitely took at least 4 months for the first one of going to these meetings and hearing it over and over again. It's not fast. It's been one of the barriers.
Okay, thank you so much, Liza. Okay, and then Dr. Satterfield, would you like to go next?
Thank you. So I've been asked, I'm from the Northern Sierra Opiate Coalition, which, as already mentioned, includes 5 counties in the northeast of the state. Our population is just over 100,000 for the entire group, so it's actually, in terms of numbers, impacted. So we started out actually with 4 counties, and when we first were looking at things, we realized that there was not a single X-waived provider in that full 4-county area that was providing medication-associated treatment, and we were pretty shocked by that, and we knew the need was there because we were number 1 actually in the entire state of California in terms of accidental deaths that were opiate associated. And so we knew we had a lot of work to do, and we're very anxious to dig in. And we've added Siskiyou County now, and we're very glad of that. And they also have a number of X-waved physicians. So as we began to look into how to tackle this problem, we discovered a number of kind of things. I guess the point of my discussion here today would be there are surprises, and to keep your eyes open for opportunities that you may have not anticipated from an unusual source. I've been asked specifically to just touch on the fact that we're using telemedicine for inductions, and we'll talk about that just real briefly. But to say some of the other surprises were that we found that some emergency physicians that often lived out of town were working in places like Alturas and Quincy, and were X-waved. And some of them actually looked forward to an opportunity to be able to use their X-wave license to help patients, but they were really not being afforded that opportunity for a variety of the obstacles that Lisa and others, and most of you probably are fully aware of. Can you hear? I'm sorry. And so we began to talk with them about prescribing and talk with the people who might be part of the obstacles and had sort of limited ability to transition that. And then to go on to telemedicine, another thing we discovered was there was a doctor about 30 miles from Quincy working in another hospital who was involved in medication-associated treatment. But it turns out he's a pain medicine specialist, and he was actually not doing it under an X-waiver. He was doing it under the nature of pain. And as I understand it, as long as the patient is actually ethically a pain patient, there's no one who will really prohibit you prescribing the medication for pain. And the doctors generally write on the bottom of the prescription, this is for pain. And then the DEA, and no one really typically has a problem with that as long as the patient has legitimate pain. So that was interesting. And then this doctor developed a contract to begin he was doing real live consultation in the Portola area and some telemedicine there. And then we adopted the Greenville clinic, and one thing or another happened, and he began coming to Quincy strictly by telemedicine. And it created an opportunity for our clinic to have a pain specialist consultation, in addition to possibly someone to enter into MAT with the patients. And a great relationship, blossomed from that situation. We don't have high numbers. We probably have about 3 or 4 inductions that have actually been done by telemedicine, but it's been quite a successful project. And so the point is, telemedicine has revolutionized healthcare, and we should look toward ways of adopting that technology, even if necessary, to having pain specialists. Now, I admit that kind of runs contrary to the concept of, your primary care provider doing the MAT, and I do think that there's some downsides. So we're hoping to have primary care providers giving the MAT as we go forward, but as an interim basis, and actually to decrease the anxiety that the providers may have had with the process. We've had a very seamless process in getting people induced. This doctor stays available by he has the patient wait in the clinic for an hour, and from there on it becomes a home induction. And of course they check the cows and the withdrawal. And then he's available by cell phone after that time period. We've not had anyone go to the ER, and then everyone is required to have a primary care physician, just as you would expect. And so if there's some sort of problem, there's someone available from primary care also to help address it. And we're decreasing the anxiety about that. So we're really hoping that we'll get some primary physicians more involved in the process. And then another surprise was that one of the physicians moved from one community to another up to the Susanville area in Lassen County, and they had no MAT providers at the time. And this doctor, in moving into a new clinic, was aware of the need for MAT and Suboxone and the X-wave doctors, and he went and got his license. So in April, he got his X waiver for the DEA, and he's been prescribing since then. I think he said he has something like 30 clients. And I wish we could claim credit for making that to happen, but it's just a happy accident that it is happening, and we're hoping to create an environment where there will be more. In Modoc County, they have a doctor that's working in their emergency department as well who would like to be prescribing, but there's the same sort of anxiety of the clinic being overwhelmed, and maybe the doctor might not be there if there's some sort of a question on the part of the patient, et cetera. So there's been inhibition to getting that going in Modoc, which we'd really like to see. So it's a going and growing process. So, any questions? Yes.
Sorry, Ravi.
I'm Kim. I'm from Lakeview Health Center in Lake County. How do you handle the prescription then of the buprenorphine through telemedicine?
Yes. So that doctor, he typically will mail them. So he will meet with the patient who's a candidate for MAT, and with the anticipation they may be inducted a week later, which is obviously a common mechanism. And he will mail them the prescription. They'll come to clinic with the medicine then, and the pharmacy does carry it. Subsequent prescriptions are also provided by him, and it is indeed an atypical situation, and we'd like to make it more foolproof. But it's been going long enough that we know that no one's running out, and there are other X-wave people who could pinch hit if necessary. Hasn't happened. We'd rather have in person by the private provider. Right. So we're going there too.
So a question we had from our live stream is, what telemedicine platform are you using? Is it just, is it a program?
Well, about the best I can do to really address that in technical terms. We started out with telemedicine with UC Davis probably well over a decade ago, and it was a system that they had, which at one time required 3 ISDN lines coming in, and now I think we have a T1 line or something, internet line, high speed. So basically we log on through the internet to a high-speed connection that connects us to the telemedicine provider, and I believe they can probably be on a laptop or pretty much anywhere that has high-speed internet. Yeah.
Other questions? Should we re-ask your question that you had? Could you reframe that again?
Can you tell us the length of visits, wait time to first intake, wait time to induction?
Actually, we're fortunate they're short. Yeah, we're not having waits. But our environment, we do have rural health clinics in each of the communities, but it isn't Indian Health Service or anything of that nature, and they are federally qualified rural health clinics. Our physicians, I think, feel to some degree almost like they're in private practice, and I think that may occur in some of the other clinics in our region, and that I think they tend to want to be protective of somewhat of an isolated environment, which is a little bit counterproductive. So we're hoping actually to do MAT at our health department, and I was inspired to get my X license because of 2 health officers I know who had active and very satisfying MAT clinics out of the Butte County Public Health and out of Yuba County Public Health. And yet the obstacles to that are significant in terms of managed care Medi-Cal. So you either have to have drug Medi-Cal or you can't really do that. And so you have to look at how is the program going to be paid for. However, if it's a rural health clinic, you're set because you are the medical home for those patients that you serve. So.
Can you comment, when you get the waiver, there's a disclosure you have to sign that says you have access to behavioral health services, that box you have to check.
Yes.
How are you guys handling that? Because in some rural communities, that's really a challenging piece of the whole thing. So how's that being handled?
So most definitely. I mean, we have an active behavioral health department through the county, which is available. And in addition, in our clinics, we have a licensed clinical social worker who does see our chronic pain patients even long before, dating back 3 years or more. Our chronic pain patients were getting urine tox screens, for example, and we're seeing the LCSW behavioral health. So now I have had conversations with some doctors who are doing MAT in clinics that don't have as much availability, and quite frankly, they say, well, we really want that, and we're doing everything possible to have it, but don't let that get in your way. And be prepared to do everything possible to get people into the behavioral health care they need and addiction treatment that they need and drug counseling. But if you have patients who need this treatment, please embark on it and do make every effort to get those other pieces as tuned up as you can.
Other questions for Mark?
Thank you.
All right, thank you very much. Okay, and then now we'll hand it over to Kim from Lake County. Thank you.
Thank you. So Lake County is very similar to the rural communities that you've spoke of. We're 58 out of 58 on quite a few measures, which I hate talking about, but just setting the stage a little bit. There's lots of work to do, and luckily in Lake County, everyone recognizes the addiction problem there. And so we have 2 hospitals in the county. We have Sutter and we have Adventist Health. Their clinics are on board. Everyone's at the table. And so we're seeing successful MAT programs being launched. Right now we have 4 facilities with 5 providers that are seeing patients, which I feel really lucky about. I think by raising the 100 to, what is it, 250 or 275 or whatever, it's going to be great. I think it'll give us a good opportunity. I was going to speak a little bit about my clinic in particular. When you see, we only see our patients that are primary to us. We don't take outside referrals at this time. The reason that we did this is we've been doing this for quite a while. We really have sort of a collaboration of physicians and behavioral health people in our facility. We have dentistry, we have specialty, we have the only HIV clinics. So we really wanted to take care of the people, all their needs, all the time. And we found that when we were in history, when we were taking them from the outside, there was a disconnect. And we didn't have success rate with them. It was a little broken, and so we just kind of closed that off and have been taking care of the patients that come to our facility with I would say a really great success rate. I mean, it's been pretty phenomenal. I'm going to try and answer your question real quick because I know you're going to ask me. No. So our intakes are 30 minutes, as far as I know. That's the initial visit with the provider. There's a team behind that provider of an LVN and MAs. They take a lot of history there. We run screens for Hep C and HIV at the same time. After that visit, then they're scheduled for a counseling appointment. And that counseling appointment is an intake and an assessment as well. And that assessment assesses for risk of a whole bunch of stuff. And I think we were using, I might be wrong on this, I know we're doing PHQ-9, I think we were using ACEs as well. From that then comes the induction date is set, and also a follow-up with the LCSW, who specializes in addiction medicine, or counseling. And so then come induction day, they come in in withdrawal, the induction happens, everybody's there for them. And then they get 2 more visits or so with the provider, or however many is really needed, but it's usually like 2 to get stable, at which time then they're scheduled for group, and group happens on days that they come in for the medicine. And then also they are suggested to still see the LCSW for monthly visits if they feel that they need that. So it's really, and then from there, if the HIV comes back positive, they're introduced to our provider for that. They're introduced dental issues, because so it's just all kinds of health is addressed at that time. We run a cures about every 3 months, more so in the beginning. Was there anything else? Am I skipping any timelines or dates? Well, I can come back to you, I guess. In the office. Mm-hmm. In the office across from my office.
What about urine tox screen monitoring?
Yeah, every time. Mm-hmm. So, yeah. I think that can I just grab my notes? I kept writing stuff down. The primary runs cures also, but that's mostly from before. We get referrals, so they can be referred, like the exit from the hospital, they can be sent to us. We usually have them, we suggest that they change their primary, and they establish with a primary care physician at our site. Yeah, I think, wow. Okay.
All right, any questions? Yes. Come back here.
I'm Aditi from Tri-City Health Center in Fremont, California, and we just recently started a MAT clinic. So I'm curious to know what your group sessions involve, like topic-wise, just generally, and then also if you've or any of the panelists have incorporated any alternative or supplemental therapy modalities like yoga or meditation or acupuncture, and how those have impacted patient treatment and adherence to medication.
I can answer a little bit to the guided meditation. I've heard the LCSWs talk about that for the patients. As far as what's going on in the group, I can give you the outline of it if we can exchange email addresses. I know a lot of it is a good portion of it is peer-led. We have an LCSW in there who kind of keeps it going, and I think that's kind of key for not getting somebody into a group setting right out of the gate, because you want them to be stable, you want them to be feeling better, you know, all the positive things to come into that group and then be supported by people who are further along than they are, and also so it doesn't really change the dynamics and bring it down, because it's all about, you know, at that point bringing them success in this process. But I don't have the outline, and so I can't answer specific, but I do know that there's an outline for that.
A little bit to that, because it was gratifying to see that our MAT action team identified early on the value of having alternative therapies, and a log of what the therapies and might be available in our community. And so our group developed a flyer that listed what was available in our community and how that can be accessed, and have spread that widely for people's information.
Liza, did you want to add anything about the alternative modalities?
We haven't done anything specifically as part of MAT, although both of the providers who do the MAT clinic do a fair amount of mindfulness stuff. And that acupuncture and mindfulness was supposed to be incorporated into the pain clinic that is a separate specialty clinic in the rural health center. So not as part of a group thing, but in other aspects.
Mark, we had a follow-up question on the live stream about the risk of the platform, the telemedicine platform being hacked. So I don't know if you have any comments on that, or.
Well, I would just say that platform is used for a wide variety of telemedicine. I do believe it's designed to be secure, but as we all know, what we think is secure may not be. I think that we've made taken every due diligence to make sure it's a secure network.
Hello, I'm Dr. Ayala from Access Community Health Pleasanton, California. I'm Dr. Ayala from Access Community Health Pleasanton, California. Thank you. My question, she mentioned that you need a PCP referral. I want your comments on patient selection for this program.
How the PCP?
How can we refer? Which patients do we select? If you can help us out with that. How do we select the patients for the referral to the select the patient?
Well, they all are required to see a PCP. Now, most of the referrals we're having are from the PCPs who have chronically habituated pain and opiate patients that they feel need further evaluation, and they are not necessarily calling that addiction, I don't think. And I think we do, because we work more in this paradigm of the referral to telemedicine consultation rather than the coaptation of primary care along with the telemedicine. I think it does change the flavor of that. I'm not sure I'm really answering your question.
So I want to know, how do we refer the patients to the suboxone program?
Oh, how are they referred?
How do we select the patients?
Oh, well, I think it's on a clinician by clinician basis. I wish it were a little more precise and better formulated, because I think we all in this room know that if you're getting over 100 morphine milligram equivalents, or getting benzodiazepines, or your pain is not well controlled. But I think it's got things like that. And so far, we've been gratified to have the numbers. That's in our community, it means that our primary providers are getting on board with the idea of medication-associated treatment, which they have not been, as you all know. Sometimes it's an uphill battle to get your primary providers to embrace it. But this group, it seems to be all moving in the correct direction.
Liza or Kim, did you have other criteria, patient selection, patient referral criteria for this?
Yeah, they're not super strict about, who comes in. It's not as if, the day you show up, you're absolutely getting an induction. So if it doesn't seem like a right fit, it's fine. And we also get a fair amount of referrals from the pain medicine clinic. So, they're coming there for pain, and they're identifying that they're having misuse or addiction issues. Some of these people are coming in, they have been paying cash before and for MAT. So some of the patients have already been on MAT that are transitioning into the rural health center. Trying to think if I'm missing any of our other referral sources. I think any of us who do primary care know which patients need to get some assistance. You see them; they're coming in for early, refills. They're getting really upset when you're not filling them. We don't have, you must have X, Y, Z in order to refer. So.
And I think we have self-referrals as well. We have patients who are just done. They're just wanting what their neighbor is feeling better, and so they want that. That's the only one I can think of.
Great, thank you. Here.
I just had a concrete question around the ongoing follow-up. And so are the patients seen every 30 days by the buprenorphine prescriber on a one-on-one basis? Is anybody doing doctor-led groups to pull this off, or how are you kind of finessing that?
We're not big enough or old enough to be at the group stage. There are some people who have been on MAT for a long period of time that they're more spaced out than every 30 days. But for the most part, our new ones are one-on-one. Yep.
Same here. They're seeing the provider, and the groups are on the day, the mornings of buprenorphine. So we have those days, some mornings, some afternoons, and the groups are at the same time in a separate wing, and then they see the doctor individually for their medication.
Okay, question here.
Hello, I'm Diane from El Dorado County, and we have a very rural population as well. And it sounds like your MAT programs are primarily focused on patients with chronic pain who are prescription opioid users in large amounts. We're finding that a lot of the patients coming through our FQHC are actually not abusing, prescription opioids, but they're actually heroin users, and we have a fair number in our MAT program. Are you seeing heroin addicts in your program as well?
Well, heroin is definitely an increasing problem in our county. We've been very fortunate in recent years where 95% of our opiate-related deaths were prescription-related, but we see the epidemic that everyone else is seeing, and it's growing in our county. So we want to be set to see those patients. Unfortunately, our rural health clinics are associated with the district hospitals, and some of the providers are not very anxious to be seeing people who are shooting IV drugs, and there's some judgmental, and some of those patients may feel less than welcome. So that's one of the reasons we really felt that our health department would be ideally suited to provide that care, which they were doing in Butte and Yuba County as well. So they're a little bit different populations. From my limited experience myself with MAT, though, it's one of the more gratifying areas of providing medication-associated treatment. Is that group of people are the most grateful, and they experience the biggest life turnarounds when they get on MAT, even beyond what the people on the oral medications see. So that should be.
We have seen heroin as part of it. I can't give you the percentage. I can get that information, but yes, and. Mm-hmm.
Okay, so a question here and then here.
So Jean Marsters again. So first, I just wanted to say that I'm just a plug for something that Kelly mentioned from the podium this morning, which is that I'm a member of the California Society of Addiction Medicine, and that we're going to be posting 12 monthly webinars on implementing MAT in primary care, primarily designed for providers in the state of California, but it'll be They'll be viewable for free. People who want CME, you might have to pay a little bit. But the content's going to be there, open access, and we're going to start it in the last week of October. So in about a month, and I'm sure Kelly will send you guys the information on that. But it'll be about things like regulations and confidentiality and monitoring patients. How should you handle patients who aren't doing well or they're triggering concern. So my question is about triggering concern. What do you guys do when a patient, you rural providers you're working with kind of a skeleton crews in many circumstances. Your communities don't have a lot of resources. What do you do with patients in your buprenorphine programs when they're not doing well? Do you have methadone clinics that you can then step them up to for more intensive care? What do you do? Do you see them once a week? Do you go to church and pray? What do you do?
Yeah, I would have to check on that. I do know that they step up the care and they have a case manager that can follow them and more closely watch them. We also have an MOU with Lake County Behavioral Health, so we have, if that's some of the issues there, we communicate that way with them so that, because sometimes they may be homeless, or public health, maybe they go and find them. So I think we have a pretty good network of everybody wanting the patient to be covered. But I would have to find out what we do if they're just failing, because I don't know that. That sounds lame.
I'm speaking less from experience than what I've read, but I know SAMHSA has a system set up to have mentors for people who are newly ex-waivered. And I know by virtue of being a part of this group that Kelly has set me personally up with people who are willing to be mentors, and there are other health officers who have great experience with this. And so I think many of the physicians that have had good experiences are anxious to promote and to help those who are just starting out. So I think there are resources available.
And I just want to say on top of that, maybe the reason I don't know that is because it's just really not happening as much as we might think. I think there's a good success rate, so I just don't know. I'm just going to say I'm sure that they're being followed and monitored and brought back in, and so I'm not. Yeah.
I was going to say similarly with that. What I've heard, because I'm not the one providing this stuff, is that it has been really quite successful, and that they haven't, they see them more frequently, but we don't have a methadone clinic anywhere nearby at all, so that's not even an option.
Okay, we have a question back here.
So my name is Danny. I'm from the county of Santa Cruz. I had a couple questions. I might have missed a couple things, but so you guys don't have no case managers? It's all the doctor doing, like intakes and all that?
We have a case manager.
And so I heard you say something about the 30-minute intake. What forms or what are you using? Are you using an ASAM? What is the intake process or forms that you're using?
Yeah, it's everything from the regular like ACEs and the intake forms that you normally have, as well as.
Or ASAM?
Now I'm confused. Okay. I can find that out for you.
Okay. And then my other question, sorry, I should speak up louder. I think that was it, I think. The intake forms, that's what I asked her. And then, okay, that's good.
Well,
one more.
Just from.
So the groups, this is my question, because we're still developing and like slowly implementing our MAT program in Santa Cruz, but we only have one primary care doctor right now that's prescribing, and from what he says, from the clients that he's been speaking with, like the clients that are just getting Suboxone for pain and the ones for heroin use, like they don't want to like be together in a group. So are you guys having separate groups, like when you do have groups, or is there separate?
Yeah.
You're splitting them up?
Mm-hmm. They're scheduled on different days, I believe.
Okay.
And just to touch on the intake, before starting Suboxone, a physician, x-ray physician or any physician, is really obliged to have a medical history available, and if there's not one in the medical record, they really need to do it. So you need to know the person doesn't have bad liver disease, and you're actually obliged somewhere in the record to know about their social history, their psychiatric history, their some detail about their substance abuse history. So really needs to be there in some form, and it's up to the intake physician if it isn't already in the record.
It was the SHA I was thinking of, I think. I think that's the form that's done. Mm-hmm.
Kimberly, there were a couple questions from the live streaming. One is, do you get referrals from county jail? And then the second one is, can you elaborate a little bit on what's happening in your group visits?
Right now, we have a patient financial services person that goes to the jail to work with patients that are going to be released or inmates that are going to be released. Other than that, we don't have a relationship there. It's kind of handled by public health, and but I was talking with a woman out there, and it looks to me like it might be an opportunity. So we're going to look into that. With groups, what was the question?
Elaborate what's happening in the group.
Yeah, you know, I wish I had that. I don't have that information. It's led by an LCSW who has addiction background, and he has tools, and he's really good, and he's nice. No, I'm just kidding. I don't know. Other than that, I'm not sure. I would have to get that information. I can share it. I know I can share it.
Okay, great. Yeah, share it with us, and then we'll put it on our website, and we'll send it out to folks. Well, unfortunately, we're all out of time, and we're all going to head into the ballroom now, but I want to thank, again, Liza, Kim, and Mark for your excellent presentations.
Thank you.